Welcome to the Deep Dive, the show where we take a mountain of information and really distill it down into those critical insights you need to be, well, truly well-informed.
That's the goal.
Today, we're plunging into a world that has profoundly shaped medicine for centuries. It's a realm of both incredible relief and immense challenge.
Absolutely.
You know, it's fascinating. The very first opioid agonist ever isolated, morphine, discovered way back in 1803 by Friedrich Serturner, a German pharmacist. It was actually named after Morpheus, the Greek god of dreams.
A very fitting name, given its effects.
Right. A powerful name for a powerful drug. And even today, it's still the benchmark, isn't it? The standard against which almost all other strong painkillers are measured.
It really is. It set the standard, and it's a history as old as medicine itself, really. That depth is precisely what we're going to explore with you today.
Okay.
We're embarking on a comprehensive deep dive into the incredibly complex world of opioids. Our mission really is to unpack their intricate pharmacology,
How they work.
their diverse clinical applications, how they're used, and their significant societal impact. We want to go far beyond the headline.
Yeah, get past the surface level stuff.
Exactly. We want to arm you with a truly professional understanding of these powerful drugs.
That's right. We're drawing from foundational texts, cutting-edge research, really building this comprehensive understanding from the ground up, literally from the molecular level.
Any interactions?
How these compounds interact with your body's cells, all the way up to their real-world implications in patient care and, unfortunately, the ongoing opioid epidemic. Our goal is for you to master this information like the elite professionals in this field.
And whether you're a seasoned healthcare professional, maybe a dedicated student, or, simply someone intensely curious about how our bodies and medications interact.
Which is fascinating in itself.
It absolutely is. This deep dive is crafted specifically for you. We're going to break down some very dense technical information.
Can you be intimidating?
It can, but we'll break it into digestible, fascinating nuggets. We want to ensure you come away not just well-informed, but with plenty of those aha moments.
Those moments that really make knowledge stick.
Precisely.
Okay, let's unpack this then. Start at the very beginning. Where do these incredibly powerful substances even come from? And what do all these terms mean? Like opioid, opiate. They get thrown around a lot.
They do, and often interchangeably, but incorrectly.
Right. I suspect there's a crucial difference.
You're absolutely right, and precision in language here is key. The journey, in many ways, starts with the opium poppy.
Papaver somniferum.
Exactly, Papaver somniferum, and also P. album. If you score the unripe seed pod, it oozes this white, milky latex. When that dries, it turns into a brown, gummy substance. That's crude opium.
Okay, the raw material.
The raw material. And from that crude opium, Serturner, back in 1803, managed to isolate the pure alkaloid, morphine.
Which was huge.
A truly pivotal moment in pharmacology. It gave us a consistent, potent compound to study and use. And naming it after Morpheus, the god of dreams, well, it really speaks to its potent sedative and dream-inducing effects.
You can see why they chose that name.
Definitely.
Okay, so back to that terminology, opioid versus opiate. What's the real deal?
Right. It's a clear distinction, though often blurred. Opioid is the big umbrella term.
Broad category.
Exactly. It covers all compounds, natural, semi-synthetic, fully synthetic, that work by hitting those opioid receptors in the body. It's the whole class.
Got it.
Opiate, however, is much more specific. It refers only to the naturally occurring alkaloids that come straight from the opium poppy.
Like morphine itself.
Precisely.
Yeah.
Morphine, codeine, the bane, papaverine, those are opiates. They're directly extracted.
Okay, that makes sense. And narcotic, where does that fit in?
Narcotic. Originally, it meant sleep-inducing.
Like narcolepsy.
Exactly. But today, especially in the U.S., narcotic has pretty much become a legal term. It's used mainly for controlled substances with abuse potential, and it can cover a much broader range of drugs than just opioids. So understanding this history, this terminology, it really sets the stage for grasping modern pharmacology.
It helps frame everything else. So it's definitely not just a simple, yes, it works, or no, it doesn't situation with these drugs. It sounds like there's a whole spectrum of action, almost like a dimmer switch instead of just on-off.
That's a perfect analogy. Opioids are far from monolithic. They are indeed categorized by their intrinsic activity or their efficacy at the receptor, how much they turn that switch up.
Okay.
So at one end, you've got the full agonists. Morphine is the classic example. They bind, they produce the maximum possible effect. They turn that dimmer switch all the way up for pain relief.
Maximum power.
Maximum power from that receptor. Then you have partial agonists. Buprenorphine is a key one here.
Right. We hear about that a lot for addiction treatment.
Exactly. These also bind, but even at high doses, they produce a weaker effect than a full agonist. It's like they can only turn the dimmer maybe halfway up no matter how much you give. There's a ceiling effect.
Ah, okay, a limit.
A built-in limit.
Right.
Finally, you have the antagonists. Naloxone is the prime example.
The reversal
It's
agent.
a reversal agent. They bind, but they do nothing themselves. They're like a key that fits the lock but won't turn it. Their job is to block the receptor, stop an agonist from working, or kick one off if it's already there. They turn the dimmer off fast.
And it's not just what they do when they bind, but also how strongly they hold on, right? Like some stick better.
Precisely. That's receptor binding affinity, how tightly they bind. Morphine, for instance, has a greater affinity, a stronger stickiness for the mu-opioid receptor, the main pain relief receptor, than codeine does.
Okay.
This difference in stickiness affects how much drug you need, how long it lasts, how easily it might be kicked off by another drug.
And then you mentioned these really interesting ones, the mixed agonist antagonists. That sounds complicated.
It adds another layer, absolutely. Take nalbuphine, for instance. These are compounds that can act as an agonist or maybe a partial agonist at one type of opioid receptor.
Like kappa.
Often kappa, yes.
Yeah.
While simultaneously acting as an antagonist at another type, usually the mu receptor.
Whoa. So they can turn one switch on and block another one at the same time.
Exactly. This dual action leads to a really diverse, sometimes complex range of effects.
Yeah.
It makes their clinical use quite nuanced. You have to know what you're doing.
And this all comes down to their shape, right? Their chemical structure. You mentioned a slight tweak can change everything.
It absolutely does. This is where pharmaceutical chemistry is just elegant. The classic opioids from opium, like morphine, are chemically complex phenanthrene derivatives. Think of them as having this specific, rigid multi-ring structure.
Like a specific key shape.
A very specific key shape. But many synthetic opioids are structurally simpler. Yet chemists have become incredibly good at manipulating these structures. A perfect example of a slight tweak making a huge difference. Take morphine, a full agonist. Make a seemingly subtle change, substitute an allyl group on its nitrogen atom, and add one hydroxyl group, and boom, you get naloxone.
The antagonist.
The potent U receptor antagonist. It's incredible how tiny molecular changes dramatically alter function, creating this whole spectrum from intense pain relief to complete blockade. It really makes you wonder, how does the body tell the difference?
It's mind-boggling. Okay, here's where it gets really fascinating for me. You mentioned our bodies actually make their own opioids. Tell me more. It's like we have a built-in pain relief system.
We absolutely do. And discovering these endogenous opioid peptides was a huge breakthrough in neuroscience.
I bet.
It showed that drugs like morphine work because they tap into pre-existing receptors in our central nervous system receptors that evolved to respond to our own natural opioid-like peptides. We have an internal pharmacy.
Wow. And it's not just one type of natural painkiller, is it? Like a whole family.
That's right. 3 main families have been identified. First, the endorphins often linked to that runner's high feeling.
Heard of this.
Second, the pentapeptide enkephalins. These include methionine enkephalin, or metenkephalin, and leucinenkephalin, leukephilin. And third, the dynorphins. Each family has slightly different preferences for the different opioid receptor types.
And how does the body make these?
It's quite sophisticated. They're cleaved or cut out from much larger precursor proteins. Like endorphins come from a big molecule called preproopiomelanocortin, or POMC,
Okay.
which fascinatingly also produces non-opioid hormones involved in stress and pigmentation. The enkephalins come from preproenkephalin and dynorphins from preprodynorphin. It's like having master blueprints that the body cuts precise sections from to create these active messengers.
So when we feel pain, our body can release these to kind of dial it down.
Exactly. Painful stimuli, even stress or anticipation of pain, can trigger their release. They then act to diminish pain perception. There are native analgesics.
But it's not always straightforward, is it?
Yeah.
You mentioned some controversies, especially with dynorphin.
Right. Well, endorphins and enkephalins are generally seen as analgesic. The role of dynorphin A, especially acting through kappa receptors, is, well, it's debated. What's really surprising, and maybe counterintuitive, is that after tissue injury or inflammation, levels of dynorphin increase in the dorsal horn of the spinal cord. And in that context, it's actually thought to increase pain and induce a state of hyperalgesia, increased pain sensitivity.
Wait, it makes pain worse?
Potentially, yes.
Yeah.
A pronoceptive action. And this seems to happen independently of the opioid receptor system itself. It adds this layer of complexity, a potential dark side, to one of our own opioid peptides.
Wow. Okay. And then there's this newer system, nociceptin, norepinephrine, FQ. That sounds like a whole other ballgame.
It is. It's a relatively novel system centered around a unique receptor called ORL1 or NOP. Think of it as a sort of distant cousin to the classic opioid receptors.
Oh.
Its own special messenger is nociceptin, also called orphanin FQ, two labs, discovered it simultaneously, hence the dual name. So we call it the NOFQ system. Crucially, nociceptin itself lacks the key chemical bit, the N-terminal tyrosine, that allows binding to classic mu, delta, or kappa receptors.
So it only hits its own NOP receptor.
Exactly. And what's fascinating is the sheer range of functions this system seems to be involved in. It's widely expressed, CNS and periphery. Research points to roles in both increasing and decreasing pain perception.
Both.
Both. Plus roles in drug reward, learning, mood, anxiety, even cough and Parkinsonism.
That's a huge range.
It's incredibly broad, which makes the NOFQ system a really promising potential target for new therapies for a whole host of conditions, not just pain. It just shows how much more there is to learn about our body's own intricate systems for managing pain and other functions.
Okay, so once these exogenous opioids, the drugs, are introduced into the body, how do they actually get where they need to go? Let's trace that journey, starting with absorption. How do they get in?
Right, the journey starts with getting into the system. And most opioid analgesics are actually absorbed quite well through common routes, subcutaneous, intramuscular, and oral.
Taking a pill seems easiest.
It is, but there's a catch, especially with oral administration. It's called the first pass effect.
Ah, the liver tax.
Exactly. Think of the liver as a very efficient processing plant or toll booth. When you swallow a drug, it gets absorbed from the gut and goes straight to the liver via the portal vein before it reaches the main bloodstream.
Okay.
Many opioids, like morphine, get significantly broken down by the liver during this first pass. So a large chunk of the oral dose might be inactivated before it ever gets a chance to circulate and reach the brain or spinal cord.
So you need a much bigger dose orally than if you injected it.
Precisely, sometimes significantly higher. And adding to the complexity, there's a lot of interpatient variability in how efficiently people's livers do this.
Meaning the same dose works differently in different people?
Exactly, which makes predicting the right oral dose tricky, often needing careful adjustment. But there are exceptions. Codeine and oxycodone, for example.
They work well orally.
They do, because they undergo less first-pass metabolism. More of the drug survives that liver toll booth.
Are there ways around that first pass effect?
Yes. Alternative routes are used specifically to bypass it. Nasal insufflation, sniffing it, allows absorption through the nasal lining directly into the blood.
Faster onset.
Often faster, yes.
Yeah.
Some with oral mucosal routes, lozenges or films that dissolve in the mouth. And for long-term, steady delivery, transdermal patches stick on the skin.
Like fentanyl patches.
Exactly. They release potent analgesics slowly over days, maintaining consistent levels, which is great for chronic pain management, avoiding peaks and troughs, and bypassing the liver first pass entirely.
Okay, so once they're absorbed, they're in the bloodstream. Where do they go then? How do they get distributed around the body?
Distribution is next. It depends on blood flow and the drug's properties, like how much it likes fat versus water. All opioids bind to some extent to plasma proteins in the blood, kind of like hitching a ride. But they leave the blood pretty quickly and tend to concentrate in tissues that get a lot of blood flow, the highly perfused organs.
Brain, lungs, liver.
Brain, lungs, liver, kidneys, spleen, yes. Those get high initial concentrations. Interestingly, skeletal muscle, while having lower concentrations per gram of tissue, acts as a major reservoir simply because we have so much muscle mass.
Okay. It soaks up a lot overall.
It does, and fat accumulation is important too, especially for highly lipophilic or fat-loving opioids.
Like fentanyl.
Like fentanyl, exactly. If it's given repeatedly in high doses, or as a continuous infusion, and it's slow to be metabolized, it can build up in fatty tissues.
And then leak out slowly.
Right. It can then slowly release back into the bloodstream over time, which can prolong the drug's effects or contribute to side effects even after the main administration has stopped.
Okay, so the body doesn't just let these drugs hang around unchanged, it starts breaking them down.
Metabolism, this sounds like a really critical step, maybe where a lot of the variability comes in.
Metabolism is absolutely crucial, and yes, a major source of variability. The body's goal is generally to convert these drugs into more polar, water-soluble metabolites, which are easier for the kidneys to excrete. The main process for many opioids is glucuronidation.
Adding a sugar molecule?
Essentially, yes. Adding a glucuronic acid molecule makes them much more polar. Let's use morphine metabolism as the prime example again because it's so well studied and clinically relevant.
Okay.
Morphine has these free hydroxyl groups, perfect spots for glucuronidation. Most of it gets converted to morphine 3-glucuronide, or M3G.
M3G, what does that do?
Now, this is fascinating and important. M3G itself isn't thought to be analgesic via the usual opioid receptors. Instead, it has neuroexcitatory properties.
Excitatory, like the opposite of sedation.
Exactly. It can cause CNS excitation, muscle twitching, myoclonus, even seizures, especially if it accumulates.
When would it accumulate? Primarily in patients with renal failure, because the kidneys are responsible for clearing it. Or sometimes with very high or prolonged morphine doses. It's a serious concern.
Wow. Okay, what else happens to morphine?
A smaller portion, maybe around 10%, gets converted to morphine 6-glucuronide, or M6G.
An M6G.
M6G is an active metabolite, and it's potent, potentially 4 to 6 times more potent as an analgesic than morphine itself.
So the body makes something even stronger.
It does. However, both M3G and M6G are quite polar, so normally they don't cross the blood-brain barrier very well.
So they don't usually cause major central effects.
Under normal circumstances, their contribution might be limited. But, just like M3G, if M6G accumulates again, say renal failure, it can cross the blood-brain barrier more readily and contribute significantly to both enhanced and prolonged opioid effects, including respiratory depression.
So kidney function is just paramount here.
Absolutely critical. And interestingly, some drugs like probenecid or drugs that block a transporter called P-glycoprotein can actually increase the amount of M3G and M6G getting into the brain.
Complicating things further.
Always.
And it's not just glucuronidation, is it? I know the liver's P450 enzymes are huge players in drug metabolism generally.
You're absolutely right. Hepatic P450 metabolism is the main route for breaking down many synthetic opioids, especially the phenylpiperdines, fentanyl, meperidine, alfentanil, sufentanil. The liver enzymes chew them up, leaving only small amounts of the original drug to be excreted.
Are there important metabolites there too?
Yes, and sometimes problematic ones. Meperidine is a key example. It gets demethylated to normeperidine.
And normeperidine.
And meperidine can cause seizures. It accumulates, especially with kidney problems or high doses. And this seizure risk is a major reason why meperidine use has significantly declined.
Makes sense. What about fentanyl?
Fentanyl is mainly metabolized by one specific P450 enzyme, CYP3A4, which is found in the liver, but also in the lining of the small intestine. Importantly, no active metabolites of fentanyl have been reported, which simplifies its profile somewhat.
Okay, now what about common ones like codeine, oxycodone, hydrocodone? How are they handled?
This group is metabolized by a different P450 enzyme, CYP2D6. And this is where things get incredibly interesting and clinically vital.
Why is that?
Because CYP2D6 metabolism actually converts these drugs into more potent opioids.
Activates them.
Essentially, yes. Codeine is demethylated to morphine. That's where most of codeine's analgesic effect comes from. Hydrocodone is metabolized to hydromorphone, which is then further conjugated. Oxycodone is metabolized to oxymorphone.
So the effect you get depends heavily on this enzyme working.
Precisely. And here's the kicker. There's huge genetic polymorphism in the CYP2D6 enzyme.
Meaning people have different versions of it.
Exactly. Think of it like having different engine speeds for this enzyme. Some people are poor metabolizers. Their CYP2D6 enzyme is slow or non-functional.
So codeine wouldn't work well for them.
Right. They get very little morphine, and since codeine itself isn't very potent, they might experience almost no pain relief. They might just get the side effects.
And the opposite, fast engines.
Yes. Ultra-rapid metabolizers. Their enzyme works overtime, converting codeine to morphine much faster and more extensively.
Which sounds dangerous.
It can be extremely dangerous. There have been tragic cases, especially in children, where ultra-rapid metabolizers given codeine experience severe morphine toxicity, leading to respiratory depression and even death.
That's terrifying.
It is. And it's the primary reason why routine codeine use, particularly post-tonsillectomy or in breastfeeding mothers, has been drastically curtailed or eliminated in many places, including the U.S. The risk is just too unpredictable.
Wow. So genetics plays a massive role in how someone responds. What about methadone? That's used a lot.
Methadone metabolism is also complex. It involves several CYP450 pathways, mainly CYP2B6, but others too. This contributes to its highly variable bioavailability and half-life between individuals.
Making dosing tricky.
Very tricky. If its metabolism is inhibited by other drugs or someone has liver problems, methadone levels can rise dangerously, leading to respiratory depression and potentially fatal heart rhythm problems like prolonged QT syndrome.
So, Looking ahead, could genetic testing become routine to help pick the right opioid?
That's absolutely the goal of personalized medicine here. While it's not standard practice everywhere yet, genetic testing for CYP450 pathways like 2D6 and others is becoming more accessible.
Hmm.
In the future, it will likely play a much bigger role in helping prescribers choose safer and more effective opioid options tailored to an individual's genetic makeup, avoiding drugs that might be ineffective or dangerous for them.
Are there other metabolic pathways besides P450?
Yes, there's also plasma esterase metabolism. Some opioids are esters, like heroin or remifentanil.
Remifentanil, the ultra-short-acting one used in anesthesia.
Exactly. These are rapidly broken down, hydrolyzed, by common estrous enzymes found in the blood plasma and tissues. Heroin, for example, is acetylmorphine.
Yeah.
It quickly gets snipped down to monoacetylmorphine and then to morphine itself, which then undergoes the glucuronidation we talked about. Remifentanil's rapid breakdown by esterases is why its effects are so short-lived.
Okay, so after all that absorption, distribution, metabolism, the body finally needs to get rid of these compounds and their metabolites. What about excretion?
Excretion is the final step, primarily handled by the kidneys. Those polar metabolites we discussed, mainly the glucuronide conjugates, are filtered out of the blood by the kidneys and eliminated in the urine.
So urine is the main way out.
Primarily, yes. Small amounts of the unchanged parent drug might also appear in the urine. Some metabolites can be excreted into the bile, but enterohepatic circulation, where substances excreted in bile get reabsorbed from the gut, isn't a major route for most opioid metabolites.
And again, this highlights the importance of kidney function.
Absolutely crucial.
Yeah.
If someone has renal impairment, if their kidneys aren't working well, these active polar metabolites, M6G from morphine, H3G from hydromorphone, potentially others can't be cleared effectively. They build up,
Leading to
prolonged sedation, increased risk of respiratory depression, and potentially that M3G-induced CNS excitation we mentioned earlier. It means dosage adjustments are often essential, and very careful monitoring is needed for patients with compromised kidney function. It really underscores how profoundly metabolism and excretion shape the overall effect of opioids, and how individual factors like genetics and organ health determine a person's response. This is truly where personalized medicine becomes so important.
Right. Now, for the really core question, the how, what's actually happening at the cellular molecular level when opioids bind? What's this intricate dance that leads to pain relief and all those other effects?
This takes us into pharmacodynamics, how the drug affects the body. The key action is that opioid agonists produce analgesia and their other effects by binding to specific G-protein-coupled receptors, or GPCRs.
Okay, the GPCR family, huge target for many drugs.
A massive family, yes. These opioid receptors are located strategically in the brain and spinal cord, in regions heavily involved in transmitting and modulating pain signals. It's also key to remember they exist peripherally too, on sensory nerve endings, especially in inflamed tissue. At the molecular level, these receptors link up with intracellular signaling molecules called G proteins, specifically the GO family. I for inhibitory.
Okay, so they trigger inhibitory signals inside the neuron.
Primarily, yes. They have two main, well-established geocoupled actions on neurons. First, on the presynaptic side, the transmitting side.
Before the synapse.
Right. They close voltage-gated calcium channels. Calcium influx is what triggers neurotransmitter release. So by closing these channels, opioids reduce the release of excitatory neurotransmitters.
Like glutamate, the main pain signal.
Exactly. Glutamate, substance P, acetylcholine, norepinephrine. Serotonin release of these from nociceptive nerve terminals is turned down.
Okay, so less pain message sent. What about the other side?
On the postsynaptic side, the receiving neuron, opioids open potassium channels,
Letting potassium out.
letting positively charged potassium ions flow out of the cell. This makes the inside of the neuron more negative, a state called hyperpolarization.
Making it harder to fire an action potential.
Precisely. It inhibits the postsynaptic neuron, making it less responsive to any excitatory signals it might still receive. So it's a double whammy, reducing the incoming pain signal and making the receiving neuron less likely to react.
So it's not just one single receptor type these drugs are binding to, is it? You mentioned different families earlier. What are the main types, the different locks in the body?
You're absolutely right. It's not just one lock. It's a set of specialized locks, each mediating slightly different effects.
Yeah.
3 major classes of opioid receptors have been clearly identified and cloned: UMU, delta, and kappa.
Mu, delta, kappa. Okay.
All 3 belong to that GPCR superfamily and share significant structural similarities. Now, pharmacologists initially proposed various subtypes within each class, like mu1, mu2, delta-1, delta-2, kappa-1, kappa-2, kappa-3, based on how different drugs seem to interact. However, molecular biology has so far only isolated one gene, encoding each main receptor type, one mo gene, one delta, one kappa. This suggests that some of the apparent subtype effects might actually come from alternate splice variants.
Meaning the same gene blueprint can be read slightly differently to produce slightly different versions of the receptor protein.
Exactly. A fascinating recent example is a specific mu-opioid receptor splice variant called MOR1D. It seems to be selectively involved in causing itch rather than suppressing pain.
Wow, that's specific.
It highlights the incredible precision these systems can have, and the fact that a single opioid drug can act differently as an agonist, partial agonist, or antagonist,
Yeah.
and with different potencies at multiple receptor classes or subtypes, is why these drugs have such a diverse range of effects throughout the body.
Can you break down what each of those main three receptors, mu, delta, kappa, is primarily responsible for? What are their main jobs?
Absolutely. Understanding their distinct roles is key to understanding opioid effects and drug development. Let's start with OMI receptors. These are arguably the most important for traditional opioid analgesia.
The main target for morphine, fentanyl?
Exactly. Mu receptor activation causes potent supraspinal and spinal analgesia pain relief originating from both the brain and spinal cord. But critically, mu receptors are also largely responsible for the major downsides: sedation, the dangerous inhibition of respiration, and the slowed gastrointestinal transit leading to constipation. They also play a role in euphoria and modulating hormone neurotransmitter release. Our endogenous endorphins have the highest affinity for mu receptors.
Okay, mu is the big one for pain relief and side effects. What about delta?
Delta receptors also contribute to supraspinal and spinal analgesia. They're involved in hormone and neurotransmitter modulation too. Our endogenous enkephalins have a higher affinity for delta receptors compared to mu or kappa. There's ongoing research into selective delta agonists, hoping they might offer analgesia with a different side effect profile, but that's still largely experimental.
And kappa, that one sounds a bit different.
Kappa receptors also mediate supraspinal and spinal analgesia. However, kappa activation is uniquely associated with some less desirable effects, notably psychotomimetic effects.
Right.
Like dysphoria, that feeling of unease, anxiety, dissatisfaction, and sometimes perceptual distortions or hallucinations. Kappa activation also contributes to slowed GI transit. Our endogenous dynorphins have the highest affinity for kappa receptors. The potential for these dysphoric effects has limited the development of purely kappa-targeted painkillers.
So understanding these different receptors and what they do, that must be the key to designing better drugs, right? The dream is a powerful painkiller without the respiratory depression, the constipation, the addiction risk. Is that achievable?
That is absolutely the holy grail, and it's where a huge amount of research effort is focused. As we said, most current opioid analgesics are primarily receptor agonists. That gives us the strong analgesia, but also the euphoria, respiratory depression, and physical dependence. Genetic knockout studies where they breed mice lacking the mu receptor really confirm its central role in these effects.
Okay.
So, one approach has been to target Q receptors more selectively. The hope was to get analgesia with less respiratory depression or addiction potential. Drugs like butorphanol and nalbuphine are examples.
The mixed agonist-antagonists we mentioned.
Some of them, yes, but they have limitations. Those dysphoric reactions can be a problem, their maximum pain relief might be lower, and interestingly, there can be gender differences in how well they work. But torphanol, for example, seems to work better in women.
Huh. Why would that be?
The exact reasons are still being explored, likely involving hormonal influences on receptor expression or signaling. It highlights how complex opioid responses can be.
So what are the newer, maybe more sophisticated approaches?
This is where it gets really cutting edge. One major area is developing biased ligands, or biased agonists.
Biased. How so?
We now understand that when a ligand binds to a GPCR, like the mu receptor, it doesn't just flip one switch. It can activate multiple downstream signaling pathways inside the cell. It's like pressing a button that starts several different machines.
Okay.
For morphine, the main analgesic effect seems to come through activating the GO pathway. But many of the adverse effects, respiratory depression, constipation, tolerance, might be more linked to activating a different pathway involving a protein called varerestin.
Ah, so different pathways for good effects and bad effects.
That's the hypothesis, or at least a preferential involvement. So A biased agonist is a drug designed to preferentially activate the desired GO pathway much more strongly than the store-arrestin pathway.
Selectively turning on the pain relief machine, but not the side effect machines.
That's the dream. The goal is potent analgesia with significantly reduced respiratory depression, constipation, tolerance, and maybe even dependence liability. This concept is also being applied to kappa receptors, trying to find biased kappa agonists that provide pain relief without the dysphoria.
That sounds incredibly promising. Are these biased drugs working in practice?
It's an active area of intense research and development. Some compounds are showing promise in preclinical studies, and a few are in clinical trials. However, some reports suggest that the observed effects of some proposed biased agonists might actually be more similar to those of partial agonists, like buprenorphine, so the exact mechanisms and clinical translation are still being worked out. It's not quite as simple as flipping one switch perfectly yet.
Still sounds like a major step forward in thinking, though. What about combining receptors or drugs hitting multiple targets? You mentioned heterodimers.
Yes, heterodimerization is another fascinating frontier. This is where two different receptor proteins physically pair up on the cell surface, forming a complex. Think of them as forming specialized molecular teams.
Like two different opioid receptors joining forces.
Exactly. For example, Mordor heterodimers, where a mu receptor pairs with a delta receptor. Studies have looked at hybrid drugs that act as a min-or agonist and a DOR antagonist simultaneously. Some results suggest this might retain analgesia while reducing tolerance and dependence compared to just hitting the MOR alone.
Interesting. So influencing both can be better than just one.
Potentially. And it gets even broader. Heterodimers can form between opioid receptors and non-opioid receptors too, opening up entirely new possibilities.
Like what?
A great example involves the MOR and the NOP receptor, that nociceptanorphin FQ receptor we talked about earlier.
Right, the cousin receptor.
A bifunctional peptide designed to activate both MOR and NOP produced significant pain relief with fewer side effects in animal models. Very promising. And even more recently, complexes between MOR and a galanin receptor, GAL1, have been implicated.
Galanin, what's that?
Galanin is another neurotransmitter system. These MOR-GL1 heterodimers seem to be involved in why methadone has lower rewarding properties compared to morphine.
Ah, so targeting these specific heterodimers could be a way to get analgesia with less potential for misuse.
That's the hope. It's a much more nuanced view of drug action than just hitting one receptor type. These structural studies are giving us blueprints for potentially much safer analgesics. But it constantly raises that crucial question. Can we truly molecularly separate profound pain relief from the potential for reward and dependence? It's the central challenge.
It really is. Okay, so we know about the receptors and the molecular actions. Where exactly do these receptors sit in our nervous system? How does activating them in different places lead to pain relief?
The location is key. Opioid receptors are densely packed in specific areas crucial for pain processing. This includes many regions in the brain, but very importantly, the dorsal horn of the spinal cord.
The entry point for pain signals from the body.
Exactly. Receptors are found both on the spinal cord neurons that transmit the pain message upwards, postsynaptically, and on the terminals of the primary afferent nerves that bring the signal in from the periphery, presynaptically.
So they can block the signal right at the gate.
Right at the spinal cord gate. Opioids acting here directly inhibit those dorsal horn pain transmission neurons. And, as we discussed, they inhibit the release of excitatory neurotransmitters like substance P and glutamate from the incoming nerve terminals. This spinal action is why epidural or intrathecal opioids drugs delivered directly into the spinal space can provide such powerful regional analgesia.
Like for childbirth or major surgery.
Precisely. You get intense pain relief in a specific body area, often with fewer systemic side effects like heavy sedation or respiratory depression, because less drug reaches the brain compared to giving it intravenously or orally.
Is there any specialization within the spinal cord? Do different receptors handle different types of pain there?
There seems to be. Research suggests other receptors in the spinal cord are strongly linked with nociceptors that respond to heat, pain, and release substance P. In contrast, all receptors seem to be more prevalent on non-peptidergic nociceptors, many of which have myelinated axons associated with mechanical pain sensitivity.
So potentially you could target mu for heat pain and delta for mechanical pain.
That's the kind of future possibility. This research opens up more targeted pain relief based on the specific type of pain signal.
Okay, so spinal action is critical, but Opioids given systemically, like a pill or IV, must also work higher up in the brain, right?
Absolutely. Systemic opioids act simultaneously at multiple levels, including crucial supraspinal sites in the brainstem and midbrain.
How do they work there?
They act on ascending pathways carrying pain signals up to the brain regions responsible for perception. But perhaps even more importantly, they powerfully influence descending pain-modulating pathways.
Pathways that go down from the brain to the spinal cord.
Exactly. These are pathways that can naturally inhibit pain signals at the spinal cord level. Key brain regions involved include the midbrain periaqueductal gray area, PAGE, the rostral ventral medulla, RVM, and the locus coeruleus.
And how do opioids influence these descending pathways?
Here's a really elegant, somewhat indirect mechanism. Opioids directly inhibit certain neurons within these brain regions, particularly inhibitory interneurons, often ones that use the neurotransmitter GABA.
So they inhibit the inhibitors.
Precisely. By inhibiting these inhibitory neurons, opioids effectively release the brakes on the main descending inhibitory neurons. This activates the descending pathways, sending stronger inhibitory signals down to the spinal cord dorsal horn.
A double negative, leading to more pain inhibition.
You got it. This indirect activation of descending control is a major contributor to the overall analgesic effect of systemic opioids. It's not just blocking pain signals coming up, it's boosting the brain's own ability to shut them down.
That's clever. And can they work even further out, like right at the site of injury, peripheral action?
Yes, that's another important layer. Peripheral action. Opioid receptors, particularly mu receptors, are also found on the peripheral terminals of sensory neurons, right out in the tissues.
So they can dampen the signal right at the source.
Exactly, especially in the context of inflammation. When tissues are inflamed, the number of opioid receptors on these nerve endings can actually increase. Activating these peripheral receptors decreases the sensory neurons' activity and reduces transmitter release locally.
Does our body use this system?
It does. Immune cells, like lymphocytes and macrophages that flock to an injury site, can actually release endogenous opioid peptides, like beta-endorphin. These act locally on the nerve endings to help counteract inflammatory pain. It's part of the body's own healing response.
Can we target this clinically?
We're starting to. Injecting opioids directly into an inflamed joint, like after knee surgery, intra-articular administration, can provide localized pain relief. And even more targeted approaches are being developed.
Why?
There's a fentanyl analog designed to work preferentially in acidic environments.
Like inflamed tissue tends to be.
Exactly. So, in conditions like colitis, where the colon tissue is inflamed and acidic, this drug could provide localized pain relief within the gut without causing the typical systemic opioid side effects like constipation or respiratory depression, because it's not as active in the normal pH environment of the rest of the body or the brain.
That's really smart drug design.
It is. And it highlights the potential for developing peripherally restricted opioids to minimize central side effects, which is a huge goal, especially for managing chronic inflammatory pain. It's a multi-pronged attack, spinal, supraspinal, and peripheral.
Okay, the science is incredible, the pain relief potential undeniable. But we absolutely have to talk about the dark side, the reason these drugs are so carefully controlled. Tolerance and dependence. These concepts loom large.
They absolutely do, and understanding them clearly is critical. Let's start with tolerance. When you use morphine or similar drugs repeatedly, even at therapeutic doses, there's a gradual loss of effectiveness.
The same dose just doesn't work as well.
Exactly. You need a larger dose to get the same original analgesic response. Tolerance actually starts developing with the very first dose at a molecular level, but it usually doesn't become clinically obvious until after maybe 2 or 3 weeks of frequent use.
Unless it's a really potent opioid?
Right. With ultra-potent ones like romifentanil used in surgery or ICU settings, significant tolerance can develop within just hours.
Wow, and what about physical dependence? Is that the same as tolerance or addiction? People often confuse these.
That's a crucial distinction, and one that professionals absolutely must understand and communicate clearly. Physical dependence is not the same as addiction, although it often accompanies tolerance when using new opioids regularly. Physical dependence is a physiological state.
The body adapting?
Exactly. The body adapts to the continuous presence of the drug. Dependence is defined by the emergence of a characteristic withdrawal or abstinence syndrome if the drug is stopped abruptly, or if an antagonist like naloxone is given.
So the body protests when the drug is removed.
That's a good way to put it. It's like the body established a new normal
Yeah.
with the drug present, and suddenly removing it throws the system out of balance, causing a rebound effect.
What causes tolerance and dependence at the cellular level? Is it just receptors getting tired?
It's more complex than just getting tired, and our understanding has really evolved. It's not simply about changes in the KMP system anymore, although that's involved. A key concept now is receptor recycling, or rather the disruption of it.
How does that work?
Normally, when an endogenous opioid binds to a mu receptor, it triggers the receptor to be pulled inside the cell, a process called endocytosis. Then it can be sort of refreshed or resensitized and recycled back to the cell surface, ready for the next signal.
Okay, a normal maintenance cycle.
Right. But fascinatingly, morphine seems to fail to induce this normal endocytosis effectively. The receptor stays on the surface but becomes less responsive. This failure to internalize and recycle is now thought to be a major contributor to tolerance and dependence.
And other opioids, like methadone.
Interestingly, methadone, which is used to treat dependence, does induce receptor endocytosis. This suggests that maintaining normal receptor sensitivity might actually require this dynamic internalization and recycling process. When it's disrupted, tolerance develops.
What other mechanisms are involved?
Another concept is receptor uncoupling. This means the receptor becomes less efficient at talking to its downstream signaling partners. The G proteins, the second messenger systems, the ion channels. It's like a breakdown in communication, likely linked to that impaired recycling. And adding another layer, some receptors, like the delta opioid receptor, might even remain functional inside the cell after being internalized, responding to ligands in certain conditions. It's a very dynamic system.
And you mentioned NMDA receptors earlier.
Yes, the NMDA receptor complex, which is usually associated with glutamate signaling and learning, plays a significant role in the development and maintenance of tolerance, and also in hyperalgesia.
How does that work?
It seems to involve increased activity in pain facilitation pathways descending from the brain. Blocking NMDA receptors, for example, with ketamine, can actually prevent or even reverse opioid tolerance in some studies.
So NMDA blockers could be used alongside opioids.
That's a major therapeutic strategy being explored. Using drugs like ketamine as adjuncts could potentially allow opioids to remain effective for longer at lower doses, mitigating tolerance development. It's about resetting that sensitized pain system. It really shows how the body's adaptation to chronic opioid use involves multiple interconnected systems.
Which brings us to this truly shocking concept. The very drugs meant to relieve pain can sometimes make it worse. Tell me about opioid-induced hyperalgesia, OIH. That sounds like a cruel paradox.
It is a paradoxical and deeply troubling phenomenon. Opioid-induced hyperalgesia, OIH, is a state where, instead of relieving pain, the persistent long-term administration of opioids actually increases pain sensitivity. Patients become more sensitive to painful stimuli.
So their pain gets worse because of the opioid, not just tolerance where the drug isn't working as well.
Exactly. It's an active increase in pain sensitivity. It's been observed with morphine, fentanyl, remifentanil. A patient might report worsening pain despite escalating opioid doses, which is a classic, so complex clinical scenario.
What could possibly cause that?
The mechanisms are still being worked out and likely involve multiple pathways. Some theories point towards activation of glial cells, the immune cells of the nervous system, perhaps via opioid receptors on them, or via morphine metabolites interacting with other receptors like TLR4 on microglia.
Okay.
Other studies suggest changes within the primary sensory neurons themselves might be key. And remember dynorphin in the spinal cord.
The one that might increase pain.
Exactly. Increased spinal dynorphin release due to chronic opioids is implicated. Activation of bradykinin pathways and, again, those NMDA receptors are also thought to be major contributors to OIH. It reinforces how complex the pain system is.
What's the clinical relevance of OIH?
It's hugely relevant. OIH is one of the major reasons why the routine, continuous use of high-dose opioids for chronic non-cancer pain is increasingly being questioned and often discouraged. It can lead to a vicious cycle. Worsening pain leads to higher opioid doses, which potentially worsens the hyperalgesia, leading to even more pain and dysfunction. It's a stark reminder that even our most powerful tools could have unexpected and detrimental effects.
Okay, so opioids clearly don't just act on pain. Their effects ripple throughout the entire body because those receptors are everywhere. Let's break down their impact on other organ systems, starting with the central nervous system, beyond just pain relief.
Absolutely. Their CNS effects are widespread. We've covered analgesia, reducing both the sensory and the crucial emotional components of pain.
That detachment feeling.
Right. Then there's euphoria dysphoria. Many users experience a pleasant floating sensation, less anxiety euphoria, which is a key driver of misuse. But others, especially with kappa-acting drugs, might feel dysphoria, restlessness, unease, just feeling bad.
Sedation.
Sedation is very common. Drowsiness, clouded thinking, though usually without significant amnesia. It makes sleep easier, especially in the elderly,
Yeah.
but patients are typically easy to arouse. The real danger comes from combining opioids with other CNS depressants like alcohol or benzodiazepines that can lead to profound sedation and respiratory arrest. And opioids mess with normal sleep cycles, reducing deep sleep.
Okay. And the big one, respiratory depression.
Respiratory depression. This is the most dangerous acute effect, the primary cause of overdose death. Opioids directly inhibit the respiratory control centers in the brainstem. They make the brain less sensitive to rising carbon dioxide levels, which normally triggers breathing.
So you just stop breathing effectively.
Exactly. It's dose-related. Severe pain can counteract it somewhat. The stimulation keeps you breathing. But if that pain suddenly resolves, the underlying depression can become dangerously apparent. It's especially risky in people with lung disease like COPD or sleep apnea or head injuries where CO2 buildup is bad. Finding ways around this, like biased agonists, is a huge research focus.
What else in the CNS?
Cough suppression. Very effective, often at lower doses than needed for pain. Codeine was classic for this. But suppressing cough can lead to retained secretions, airway obstruction, pneumonia, meiosis pinpoint pupils, a classic sign. It's mediated by the parasympathetic nervous system, and importantly, very little tolerance develops to this. It's a reliable sign in overdose. Truncal rigidity. High doses of potent opioids like fentanyl, given quickly IV, can cause stiffness in the chest and abdominal muscles, making ventilation difficult. Nausea and vomiting, very common. They stimulate the chemoreceptor trigger zone in the brainstem, often worse when moving around, suggesting a vestibular component. Temperature. More agonists can cause hyperthermia, fever, kappa agonists hyperthermia, and as mentioned, disrupted sleep architecture. Less deep sleep, more risk of sleep apnea.
And their effects reach far beyond the CNS too, right? The peripheral effects seem just as significant, maybe even more persistent.
Absolutely. The peripheral effects are profound and often cause major clinical challenges. In the cardiovascular system, most opioids actually have minimal direct effects on the heart muscle itself, though bradycardia, slowed heart rate, is common. Meperidine is an exception. Its anticholinergic effect can cause tachycardia, fast heart rate, and it can weaken heart contractions. Blood pressure usually stays stable unless the patient is stressed or hypovolemic, low blood volume. Then you can see hypotension due to vasodilation. And that CO2 buildup from respiratory depression can dilate cerebral blood vessels, raising intracranial pressure bad in head injury.
The gut effects are notorious, aren't they? Constipation.
Gastrointestinal tract effects, especially constipation, are almost universal and incredibly problematic because, unlike many other effects, tolerance does not develop significantly.
So it persists even with long-term use.
It persists. Opioid receptors are incredibly dense throughout the gut's own nervous system. Opioids decrease stomach motility, increase tone in the small intestine while decreasing propulsion, and slow down transit through the large intestine, leading to hard, dry stools. It's a major quality of life issue for chronic pain patients and often requires specific management with laxatives or those peripherally acting antagonists we discussed.
What about other systems?
Biliary tract. Opioids contract the sphincter of Oddi, the valve controlling bile flow, which can cause severe pain, biliary colic, and potentially lead to pancreatitis due to reflux. Renal. Kidney function can be depressed due to reduced blood flow. There's an antidiuretic effect, and increased bladder and ureter tone can cause urinary retention, especially post-operatively, and worsen kidney stone pain. Uterus may prolong labor, though mechanisms aren't fully clear. Endocrine. They simulate release of ADH, prolactin, growth hormone, but inhibit LH release. Chronic use often leads to low testosterone in men, hypogonadism, and menstrual problems in women. Pruritus, itching, common, especially with spinal administration. It involves both central mechanisms and peripheral histamine release. Flushing and sweating can also occur. Interestingly, kappa agonists can sometimes treat this itch. Immune system, complex effects. While immune cells release endogenous opioids locally to reduce inflammation, systemic opioids generally suppress some immune functions, like natural killer cell activity, which could theoretically impact infection risk or tumor surveillance, though the clinical significance is still debated. These diverse effects really stem from that wide receptor distribution, highlighting why managing opioid therapy requires a holistic view of the patient.
Okay, understanding the basic science and the widespread effects is crucial. Now, how do we translate that into actually using them safely and effectively in clinical practice to manage pain? Let's get into the clinical pharmacology.
Right. This is where the rubber meets the road. And it always starts with good pain assessment and setting clear treatment principles.
Pain is subjective, right? How do you measure it?
It's challenging. We use tools like the numeric rating scale, NRS 0 to 10, or the visual analog scale, VAS, align patients' mark. For kids or nonverbal adults, observational scales like FLACC or the Wong-Baker Faces scale are helpful. But assessment goes beyond just intensity. We need to understand the type of pain, its impact on function, using tools like the brief pain inventory or condition-specific scales like the oswestry for back pain. What can the patient do or not do because of the pain?
And goals are key.
Absolutely critical. Establish clear, realistic goals before starting opioid therapy, focused on improving function and quality of life, not just chasing a zero pain score. This needs to be a shared decision with the patient and family. Then, frequent monitoring and reevaluation are essential. Is the treatment working? Are there side effects? Does the plan need modification? And we have to differentiate clearly between managing acute pain versus chronic pain. The risks and strategies are very different.
So how are opioids typically used for different types of pain?
For severe acute pain, think major surgery, trauma, heart attack, strong agonists like morphine, hydromorphone, fentanyl are often the go-to, usually parenterally initially. They tend to work best for continuous, dull, aching pain rather than sharp, intermittent pain.
What about cancer pain?
Cancer pain management is often complex and aggressive, frequently requiring a multidisciplinary approach. Continuous use of potent opioids is common and often necessary, especially as the disease progresses. But the emphasis now is strongly on multimodal analgesia.
Combining different types of drugs.
Exactly. Using opioids alongside non-opioids like NSAIDs, acetaminophen, nerve pain medications like gabapentin, or procedural techniques like nerve blocks. This allows for lower overall opioid doses, reducing side effects and the risk of tolerance. The WHO analgesic ladder provides a framework, starting with non-opioids and stepping up as needed. For continuous pain, scheduled, fixed-interval dosing is generally better than waiting for pain to become severe on-demand dosing.
And those long-acting pills?
Sustained-release formulations like MS-Contin, morphine, or OxyContin, oxycodone, provide more stable blood levels for chronic pain. However, for long-term chronic non-cancer pain, there's actually very little evidence they're superior to non-opioid strategies, and they carry significant risks. For breakthrough pain in cancer patients already on long-acting opioids, rapid-acting formulations like oral transmucosal fentanyl, the lollipop, or film can provide quick relief.
What about specific situations like labor or colic?
In obstetric labor, opioids cross the placenta, so the risk of neonatal respiratory depression is a concern. Meperidine used to be favored as potentially causing less depression than morphine, but its use is declining overall. Naloxone can reverse neonatal depression if needed. For renal or biliary colic, the pain can be excruciating, often requiring strong agonists. But there's that paradox: the opioid might increase smooth muscle spasm, potentially worsening the pain transiently, so it needs careful use.
Beyond pain, what are the other main clinical uses? You mentioned a few earlier.
Right. Acute pulmonary edema from heart failure, IV morphine can provide remarkable relief from shortness of breath, likely by reducing anxiety and cardiac workload. Their diuretics like furosemide might be preferred if respiratory depression is a major concern. Cough suppression, though less common now with effective non-addictive alternatives like dextromethorphan. Diarrhea control synthetic opioids like loperamide that act peripherally are very effective and widely used over the counter. Shivering, especially post-operatively, meperidine works well due to its alpha-2 effects, and of course their huge role in anesthesia.
Yeah, tell me more about anesthesia. They seem indispensable there.
They really are. Used as pre-medication before surgery for sedation and anxiety relief. Used intraoperatively for induction and maintenance of anesthesia, especially in cardiac or high-risk surgery, where minimizing cardiovascular stress is vital, though this usually necessitates mechanical ventilation. And crucial for postoperative analgesia. Plus, their use as regional analgesics via epidural or spinal routes.
Right, the direct spinal application.
Exactly. Provides targeted, long-lasting pain relief with fewer systemic side effects, often combined with local anesthetics to further reduce the need for systemic opioids. For chronic severe pain, implantable pumps delivering opioids directly to the spine are an option.
Given these varied uses, there must be lots of ways to get these drugs into the system besides pills and shots. What about those alternative routes?
Definitely. Several alternative routes offer advantages in specific situations. Patient-controlled analgesia, PCA, is very common, especially after surgery.
Letting the patient push the button.
Right. They control an IV pump, delivering a small, preset dose when they feel pain, but with safety lockouts to prevent overdose. It generally leads to better patient satisfaction. but requires careful setup and monitoring, including pulse oximetry, especially if other sedatives are on board, because overdoses can still happen. Rectal suppositories, morphine, hydromorphone, are an option if patients can't take oral meds. Transdermal patches, like the fentanyl patch, Duragesic, deliver potent opioids slowly through the skin over several days.
Good for stable, chronic pain.
Primarily indicated for persistent, severe cancer pain in patients already tolerant to opioids, requiring at least 60 milligram oral morphine equivalent daily. Absorption can be variable, heat increases it, and peak effects take a day or two. Its use in chronic non-cancer pain is debated due to risks and lack of clear superiority evidence. The buprenorphine patch, Butrans, is another option for chronic pain or maintenance. Buccal transmucosal sentinel, the lozenge or film dissolved in the cheek, offers rapid absorption for breakthrough cancer pain. And the intranasal route butorphanol is available this way in the U.S. It avoids first-pass metabolism and offers rapid onset. We might see more drugs via this route in the future.
With all these powerful effects and uses, we absolutely need to cover the downsides systematically. What are the key toxicities and undesired effects clinicians need to anticipate and manage?
It's a long list, unfortunately, reflecting their potent and widespread actions. For acute use, short-term administration, the main concerns are respiratory depression, most dangerous, nausea, vomiting, pruritus, itching, urticaria, hives, constipation starts immediately, urinary retention, delirium or confusion, sedation, myoclonus, muscle jerks, and potentially seizures, especially with meperidine or tramadol or in overdose.
And with chronic, long-term use, the list gets longer.
It does, and different issues emerge. For chronic use, we worry about hypogonadism, low sex hormones, immunosuppression, potential, debated, increased feeding weight gain, altered growth hormone secretion, persistent constipation, the development of tolerance, physical dependence leading to withdrawal effects upon cessation, the complex issue of abuse addiction or opioid use disorder, opioid-induced hyperalgesia, increased pain sensitivity, and impairment of functions like driving.
Okay, this is where we really need to nail down the differences between tolerance, physical dependence, and addiction. They often get lumped together, but they're distinct, right? Especially for understanding the risks and managing patients.
Absolutely critical distinction. Let's break it down carefully. Opioid tolerance revisited. It's the diminishing effect with repeated doses, needing more drug for the same relief. Starts with the first dose, clinically apparent after 2-3 weeks usually, but can be hours with potent IV drugs like remifentanil, minimized by smaller doses, longer intervals.
And we tolerate different effects differently.
Exactly, that's differential tolerance. High tolerance develops to analgesia, euphoria, sedation, even respiratory depression, though overdose is still possible.
Yeah.
But crucially, little or no tolerance develops to meiosis, pinpoint pupils, or constipation. Those effects persist. Tolerance to nausea vomiting often develops over days or weeks. It's variable.
What about cross-tolerance? Tolerant to one means tolerant to others.
Generally, yes, especially among mu agonists. If you're tolerant to morphine, you'll likely have some tolerance to fentanyl or hydromorphone, but it's often partial or incomplete. This is the basis for opioid rotation in cancer pain. Switching drugs can sometimes recapture analgesia at a lower equivalent dose because the cross-tolerance isn't total. And adjuncts like NMDA antagonists, ketamine, might help reverse tolerance.
Okay, tolerance is the body adapting to the drug's effects. Now, physical dependence.
Physical dependence is the body adapting to the drug's presence. It's defined by the emergence of that withdrawal abstinence syndrome when the drug is stopped or blocked. It invariably accompanies tolerance with chronic mu-opioid use.
And the withdrawal symptoms.
Think severe flu, but worse. Runny nose, tearing, yawning, chills, goosebumps, cold turkey, muscle aches, cramps, nausea, vomiting, diarrhea, anxiety, agitation, dilated pupils, sweating, insomnia. Intensity depends on the level of dependence. Giving an opioid suppresses these symptoms almost immediately.
How long does withdrawal last?
Depends on the drug's half-life. Short-acting ones, like heroin or fentanyl.
Yeah.
Onset 6-10 hours, peak at 36-48 hours, mostly done by 5 days, though some symptoms linger. Longer-acting methadone. Onset delayed for days, peak slower, lasts up to 2 weeks or more. It's milder but much more prolonged, which is why it's used for detoxification. Importantly, even after physical withdrawal resolves, psychological craving can persist for a long time.
And precipitated withdrawal, that sounds nasty.
Antagonist-precipitated withdrawals when you give an antagonist like naloxone or even a partial agonist like buprenorphine to someone physically dependent on a full agonist. It rips the agonist off the receptors, causing an immediate, intense, and potentially dangerous withdrawal syndrome. Needs very careful management.
Okay, so tolerance and physical dependence are physiological adaptations. How is addiction different? This is the term that carries so much stigma and misunderstanding.
This is the most critical distinction. Addiction, now often termed opioid use disorder, OUD, in clinical settings, is not just physical dependence. The American Society of Addiction Medicine defines it as a primary chronic disease of brain reward, motivation, memory, and related circuitry. It's characterized by a pathological pursuit of reward relief through substance use.
So it's about behavior and brain changes.
Exactly. Key features include inability to consistently abstain, impairment in behavioral control, compulsion, intense craving, diminished recognition of significant problems with one's behaviors and relationships, and a dysfunctional emotional response. Crucially, use continues despite negative consequences. Addiction is a complex biopsychosocial disease. You can be physically dependent without being addicted. For example, a cancer patient appropriately managed on long-term opioids, although physical dependence is often present in addiction.
So managing the risk of addiction is paramount when prescribing.
Absolutely. Even short exposures can increase long-term use risk. Key principles for minimizing harm include: use non-opioids multimodal therapy first, especially for chronic pain. Constantly reevaluate the need for opioids. Set clear functional goals before starting. Use the lowest effective dose. Consider treatment agreements. Monitor for aberrant behavior via PDMPs. Educate patients on risks. Safe storage disposal. Discuss naloxone availability, exit strategies, tapering. It requires vigilance and open communication.
Given the risks, overdose is a terrifying reality. What's the immediate intervention? You mentioned naloxone earlier.
Yes, so naloxone is the specific antidote, the lifesaver. Administered intravenously, intramuscularly, or intranasally, it rapidly reverses the coma and respiratory depression of opioid overdose.
So fast.
Within minutes, often 1-3 minutes, 4th EM. Respiration normalizes, consciousness returns, pupils dilate, bowel activity resumes. Pain returns too, of course. Speed is critical. Preventing brain damage from lack of oxygen is paramount. So establishing respiratory support while getting naloxone ready is key. Don't delay breathing support.
And the issue with fentanyl needing more naloxone.
That's a huge challenge now. Illicit fentanyl and its analogs are so potent and bind so tightly that standard naloxone doses might be insufficient. Repeated doses, sometimes 10 times higher than traditional doses, may be needed to reverse the overdose and maintain breathing until the fentanyl wears off.
Which can take a long time.
It can. This highlights the absolute necessity of widespread naloxone availability intranasal kits, auto-injectors for first responders, and the community. Every second counts. For newborns with opioid exposure, much smaller, specific doses are used.
Can naloxone be used for anything besides full overdose reversal?
Yes, there's a growing role for low-dose naloxone, like 0.04 milligram IV, to carefully manage side effects like itching or nausea from therapeutic opioids, example epidural morphine, without reversing the pain relief. It requires careful titration. And then there are those peripherally acting antagonists.
Right, for constipation.
Exactly. Oral naloxone, poorly absorbed, methyl naltrexone, naldomidine, naloxegol, alvemopan. They're designed not to cross the blood-brain barrier significantly. So they block MUL receptors in the gut to treat opioid-induced constipation, OIC, or post-op ileus, without causing central withdrawal or affecting analgesia. It's targeted therapy.
What about naltrexone, the longer-acting one?
Naltrexone is mainly used for relapse prevention and OUD maintenance treatment. Its long duration means a single dose can block heroin's effects for 1-2 days, reducing the reward and craving. It's also FDA approved to reduce alcohol craving and can aid smoking cessation. It's a tool for long-term recovery.
So who absolutely should not take opioids or needs extreme caution? What are the major contraindications?
Several critical situations require extreme caution or avoidance. First, combining pure agonists with weak partial agonist mixed agents, like pentazocine with morphine. This can reduce pain relief or precipitate withdrawal in dependent patients. Bad combination. Second, patients with head injuries. Opioid-induced respiratory depression raises CO2, dilates cerebral blood vessels, and can dangerously increase intracranial pressure if it's already high, potentially lethal. Third, pregnancy. Chronic opioid use leads to fetal dependence and neonatal abstinence syndrome, NAS, after birth withdrawal in the newborn, requiring intensive care. A tragic consequence of the epidemic. Treatment involves supportive care and sometimes opioid replacement. Morphine, methadone, buprenorphine for the infant. Fourth, patients with severely impaired pulmonary function. COPD, asthma. They have little respiratory reserve, and opioids can tip them into acute respiratory failure. Fifth, impaired hepatic or renal function. Metabolism and excretion are slowed. Active metabolites like morphine's M3, GM6G accumulate, increasing risk of sedation, respiratory depression, and seizures. Dose reduction and close monitoring are essential. Sixth,
Certain endocrine diseases like Addison's disease, adrenal insufficiency, or severe hypothyroidism, myxedema. Patients may have prolonged and exaggerated responses.
And interactions with other drugs, that must be a minefield.
It absolutely can be. Always need a thorough medication history. Key interactions to watch for: sedative hypnotics, benzodiazepines, barbiturates, alcohol, additive CNS depression, especially respiratory depression. This combination is incredibly dangerous and a frequent cause of fatal overdoses. Antipsychotic agents, increased sedation, variable respiratory effects, potential worsening of cardiovascular effects. Monoamine oxidase inhibitors, MAOIs, this is a major one, a relative contraindication for all opioid analgesics. High risk of hyperpyrexic coma, high fever, coma, or severe hypertension. Can be fatal. Extreme caution needed. Preventing these interactions is a core part of safe opioid therapy.
Okay, we've laid a really solid foundation on how opioids work, their effects, and how they're used clinically. Now let's zoom in on some of the specific agents, the key players in the opioid family. What makes each one unique? Let's start with the heavy hitters, the strong agonists.
Right, the strong agonists are typically used for severe pain. Within the phenanthrene chemical class, you have the prototype, morphine, still widely used, the standard for comparison. Then there's heroin, or diamorphine. It's basically morphine with 2 acetyl groups added, making it more fat-soluble, so it crosses the blood-brain barrier faster, giving a quicker, more intense rush, which contributes to its high abuse potential. It's prohibited in the US and Canada, but used medically elsewhere. Interestingly, studies haven't consistently shown it's superior to morphine for pain relief when given by standard routes like IM injection. Hydromorphone, diloted, and oxymorphone, opana, are also potent phenanthrenes. Similar efficacy to morphine, but more potent by weight, you need less milligrams. Hydromorphone is very commonly used in hospitals.
What about methadone? That one seems unique.
Methadone is in a different chemical class, the phenylephtalames, and it is unique. It's a potent receptor agonist, yes, but it also has other important actions. It blocks NMDA receptors and inhibits the reuptake of serotonin and norepinephrine.
The triple threat almost.
Kind of. This complex mechanism likely explains why it can be effective for difficult pain types, like neuropathic pain or cancer pain, sometimes even when morphine fails. It's a key player in opioid rotation. But its pharmacokinetics are notoriously variable.
The long, unpredictable half-life.
Exactly. Typically 25-52 hours, but huge variation. This makes dosing tricky and requires slow titration and careful monitoring for delayed respiratory depression and heart rhythm issues, QT prolongation. It's metabolized by multiple CYPs, mainly 2B6, 3A4. Crucially, tolerance and physical dependence develop more slowly with methadone, and the withdrawal syndrome is milder but more prolonged than with morphine or heroin.
Which is why it's used for OUD treatment.
Precisely. Its long duration, oral effectiveness, and slower onset of withdrawal make it ideal for detoxification and long-term maintenance therapy, reducing cravings and illicit opioid use.
Okay, now the phenylpiperidines, fentanyl, and its relatives, these are incredibly potent.
It's extremely potent. Fentanyl itself is a synthetic opioid, about 100 times more potent than morphine. Widely used in anesthesia, a pupillary epidural, and for severe chronic pain, transdermal patch, due to its potency and relatively short duration after single doses. Its family includes even more potent or faster, shorter-acting relatives. Sufentanil, 5 to 7 times more potent than fentanyl. Alventanil, less potent than fentanyl, but faster onset, shorter duration. And remiventanil.
The ultra-short one.
Right, metabolized incredibly quickly by plasma esterases, giving it a half-life measured in minutes, perfect for controlled infusions during surgery. And then there's carfentanil.
The elephant tranquilizer.
Essentially, yes. Used in veterinary medicine for large animals. It's about 10,000 times more potent than morphine, 100 times fentanyl. Its appearance as an adulterant in illicit drug supplies is a major driver of overdose deaths due to its extreme potency. Tiny amounts can be lethal.
What about meperidine, Demerol? It used to be common.
Meperidine is an older phenylpiperidine. Its use has declined significantly. It has notable antimuscarinic effects, can cause fast heart rate, can weaken heart contractions, and crucially, its metabolite normoperidine accumulates and can cause seizures, especially with poor kidney function or high doses. Not a good first-line choice anymore.
Any others in the strong agonist category?
There's levorphanol, a morphinin derivative. It's a synthetic opioid structurally similar to morphine, but with a broader profile. It hits mu, delta, and kappa receptors, inhibits serotonin norepinephrine reuptake, and blocks NMDA receptors, like methadone, a complex agent used for severe pain.
Okay, moving down in potency. What about the mild to moderate agonists? These are probably the ones people encounter most often for things like dental pain or after minor surgery.
Exactly. These are very common outpatient prescriptions. Again, starting with phenanthrines. Codeine is the classic example. As we discussed, it's actually a prodrug. It needs to be converted to morphine by CYP2D6 to have significant analgesic effect. Its own affinity for opioid receptors is low. Side effects often limit the dose you can give. Used for mild to moderate pain and cough, but concerns about variable metabolism are reducing its use, especially in kids. Hydrocodone is similar, usually combined with acetaminophen like in Vicodin and Norco. It's metabolized to hydromorphone. Oxycodone is more potent than codeine or hydrocodone. Often prescribed alone, OxyContin for controlled release, immediate release for acute pain, or combined with acetaminophen, Percocet, or aspirin, Percodan, used for moderate to severe pain. Abuse potential led to reformulated versions designed to deter crushing and REMS programs. In the phenolphthaleamines, there was propoxyphene, Darvon, Darvise, chemically related to methadone but very weak analgesic, withdrawn from the U.S. market due to cardiac toxicity risks and limited efficacy. Among phenylpuparidians, we have agents mainly used for diarrhea, diphenoxylate combined with atropine and Lomotil, and its metabolite defnoxin, low abuse potential due to formulation and poor solubility, and loperamide, Imodium, which acts peripherally on gut opioid receptors with minimal CNS entry, very effective for diarrhea, available over the counter.
Now, for those fascinating mixed action drugs, the ones that can be agonists and antagonists, these sound tricky to use.
They require careful understanding, yes. The big caution is giving them to someone already on a pure agonist like morphine. You risk reducing their pain relief or worse, triggering withdrawal, because these drugs often block or only partially activate the mu receptor.
Buprenorphine is a major one here, isn't it? Used a lot for OUD.
Buprenorphine, Suboxone, when combined with naloxone, is a key phenanthrine derivative with mixed actions. It's a partial agonist at the U receptor.
Meaning it has that sealing effect.
It's exactly. High intrinsic affinity binds tightly, but low intrinsic activity doesn't fully activate the receptor. This limits its maximal analgesic effect and, importantly, its maximal respiratory depression compared to full agonists. It also acts as an antagonist at kappa and delta receptors and binds to the ORL1 and OP receptor. Its dissociation from the mu receptor is very slow, leading to a long duration of action and making its effects difficult to reverse with naloxone.
Which is good for maintenance therapy.
Yes, its long duration and partial agonism make it effective for OUD treatment, similar efficacy to methadone in structured programs. The sealing effect was initially thought to make it much safer in overdose, but serious respiratory depression can still occur, especially if injected illicitly with benzodiazepines. The combination with naloxone, Suboxone, is designed to deter IV misuse. The naloxone is poorly absorbed orally but becomes active if injected, precipitating withdrawal. It's also available as a patch, Butrans, and implant, Probufene. Managing acute pain in patients on chronic buprenorphine is a real challenge due to its high affinity blocking other opioids.
What about kratom? That seems to be popular but controversial.
Kratom is an extract from a Southeast Asian plant. Its active compounds, metragenine and 7-hydroxymetragenin, appear to act as partial receptor agonists in preclinical studies, but there's no robust clinical evidence of benefit, and there are increasing reports of serious harms, contamination, salmonella, seizures, liver toxicity, withdrawal, and even deaths. Regulatory agencies consider it unsafe and ineffective currently. Needs much more rigorous research.
Any other mixed agents?
Yes, in the benzomorphin class, there's pentazocine, Talwin, an older drug, primarily a KAT agonist with weak antagonism or partial agonism, available orally and parenterally. Nalbuphine, Nubain, is a strong agonist and a partial antagonist, given parenterally. Like buprenorphine, it has a sealing effect for respiratory depression, but can be hard to reverse if it occurs, notably effective for opioid-induced itching. And in the morphinins, butorphanol, Statal, mainly a agonist, similar profile to nalbuphine but maybe more sedating, available parenterally and as a nasal spray.
Okay, and then there are a few miscellaneous analgesics that have some opioid-like features but aren't typical opioids. Tramadol and tapentadol.
Right, these are interesting because they have multiple mechanisms of action. Tramadol ultram is centrally acting. It's a very weak agonist itself, and its main metabolite, M1 formed via CYP2D6, is a stronger mu agonist. But a large part of its analgesic effect comes from inhibiting the reuptake of serotonin and norepinephrine, similar to some antidepressant drugs.
So its effect isn't fully blocked by naloxone.
Only weakly, confirming its dual mechanism. Its effectiveness depends on that CYP2D6 conversion, so genetic variations matter. Big concerns with tramadol are seizure risk, especially in those with epilepsy or on other seizure-lowering drugs, and serotonin syndrome if combined with SSRIs or other serotonergic drugs. Nausea and dizziness are common, but often improve. It generally causes less respiratory depression than traditional opioids when used alone at therapeutic doses. Tapentadol, Nucynta, is newer. It also has dual action, modest opioid receptor affinity, plus significant norepinephrine reuptake inhibition. It has less effect on serotonin reuptake compared to tramadol.
So maybe less risk of serotonin syndrome.
Potentially, yes. Studies show its analgesia is moderately reduced by naloxone, but strongly reduced by alpha-2 blockers, which interfere with norepinephrine effects, confirming its reliance on both mechanisms. It's shown similar efficacy to oxycodone for moderate severe pain, but often with fewer GI side effects like nausea and constipation, which is a big plus for patients.
And finally, within the opioid family or related compounds, some are specifically used just for cough, right? The antitussives.
Yes, some opioids have potent cough suppressant effects, often at doses lower than those needed for pain relief. The mechanism isn't fully understood, but seems to involve different central receptors or pathways than analgesia. Dextromethorphan is a prime example. It's the dextro or right-handed stereoisomer of a levorphenol derivative. The levoisomer has opioid effects, but dextromethorphan is generally considered non-addictive and causes less constipation than codeine. It's very common in over-the-counter cough syrups. It also has some NMDA receptor blocking activity. However, abuse of high doses of purified dextromethorphan can cause dissociative effects and serious toxicity. Its use in young children, 6 years, is now discouraged due to safety concerns. Codeine itself is also used as an antitussive at low doses, foreseeable in 15 milligram, but again, metabolic variability is a concern. Levopropoxyphene is another stereoisomer example. It's the isomer of the withdrawn weak opioid dextropropoxyphene. Levopropoxyphene has no opioid effects but retains antitussive action, though sedation can be a side effect. Like all opioids-related compounds, caution is needed with MAOIs.
Okay, we've covered the agonists and mixed agents extensively. Now, if these drugs can be so powerful, sometimes dangerously so, what about turning them off? Let's talk about the pure opioid antagonists, the reversal agents.
This is where we have specific tools to counteract opioid effects, most importantly in overdose. The key pure antagonists are naloxone, naltrexone, and nalmefene. Chemically, they're morphine derivatives, but with bulky groups attached that change their function entirely. They have high affinity, especially for opioid receptors, binding tightly but without activating them. They act as competitive blockers.
So they kick the agonists off the receptors.
Or prevent them from binding in the first place. They can reverse the effects of agonists at mu, delta, and kappa receptors.
How do they differ in how they're used or how long they last?
Their pharmacokinetics are key here. Naloxone is the workhorse for acute overdose, usually given by injection, IM, SC, or intranasally. Its defining feature is its short duration of action, typically only 1 to 2 hours. This is much shorter than most opioid agonists. It's rapidly metabolized by glucuronidation. Naltrexone is much longer acting. It's absorbed orally but has significant first-pass metabolism. Still, its half-life is around 10 hours. A single oral dose can block heroin effects for up to 48 hours. This makes it suitable for relapse prevention and OUD treatment. A long-acting injectable depot formulation is also available, lasting weeks to months. Nalmefene is the newest, given orally. It has a longer half-life than naloxone, 8-10 hours, potentially useful for longer-acting opioid overdoses, but less commonly used than naloxone overall.
And pharmacodynamically, what do they do on their own? Anything.
When given alone, without any opioid agonist present, they are remarkably inert. They cause essentially no effects at the doses needed to block opioids. They are silent blockers.
But if an opioid is present,
then their effect is dramatic. 40 naloxone reverses opioid effects, respiratory depression, coma, pinpoint pupils, sedation within 1-3 minutes. It's incredibly rapid. But if given to someone physically dependent on opioids,
precipitated withdrawal.
Instantaneously.
Yeah.
A very severe abstinence syndrome. And importantly, you don't develop tolerance to the antagonist effect, nor do you get withdrawal from stopping the antagonist itself.
So the main use is acute overdose reversal with naloxone. Are there other clinical uses?
Yes. Besides overdose, low-dose naloxone can be carefully titrated IDE to treat side effects like itching or nausea from therapeutic opioids like epidural morphine without reversing analgesia. And those peripherally acting mu opioid antagonists, Pamoras like methylnaltrexone, naloxegol, nalobamidine, alphamopan, are specifically designed to treat opioid-induced constipation or postoperative ileus by acting only in the gut, not crossing into the brain, a very targeted approach. Naltrexone, as mentioned, is used for long-term maintenance therapy for OUD and also FDA approved to reduce alcohol craving. It's also being explored in combination therapies for weight loss and smoking cessation. These antagonists are critical tools, both for emergencies and for managing the chronic consequences of opioid use.
We've journeyed through the intricate science, the clinical applications, the good and the bad. But we absolutely cannot conclude this deep dive without addressing the elephant in the room, the opioid epidemic. It's a public health crisis of staggering proportions, especially here in the U.S.
It is a devastating crisis with complex roots and far-reaching consequences. The U.S. consumes the vast majority of the world's prescription opioids and has seen decades of escalating opioid-related harm and death. Drug overdose is now the leading cause of accidental death in the U.S., overwhelmingly driven by opioids. And the line between prescription and illicit opioids has blurred tragically. In 2020 alone, over 68,000 opioid overdose deaths occurred in the U.S., part of over 100,000 total drug overdose deaths between 2020 and 2021. These aren't just numbers. They represent shattered families and communities.
What factors led to this situation? How did prescribing get so out of hand?
It was a confluence of factors, a perfect storm, some might say. Aggressive marketing by pharmaceutical companies certainly played a role, often downplaying addiction risks. There was misleading industry-funded education for clinicians. An often unjustified assumption took hold that opioids were superior for chronic non-cancer pain, despite limited long-term evidence. And critically, there was, and still is, a paucity of readily accessible, effective, and affordable non-opioid pain management strategies. Insurance reimbursement often favored cheap opioid pills over more comprehensive multidisciplinary pain care, physical therapy, or interventions. Opioids filled a vacuum, sometimes inappropriately.
So, faced with this crisis, what has been the response from healthcare systems, government agencies? It must require action on many fronts.
It absolutely does, and the response has been multifaceted, though arguably slow to start and still evolving. Key initiatives include the CDC Opioid Prescribing Guidelines, first in 2016, updated 2022, aimed at primary care, emphasizing non-opioids first for chronic pain, careful initiation, and risk mitigation. The HHS Interagency Task Force on Pain Management Best Practices, offering drawn-or guidance. FDA actions like requiring risk evaluation and mitigation strategies, REM, for potent opioids, including mandatory prescriber education and enhanced warning labels. State-level regulations from medical boards, and crucially, the implementation of prescription drug monitoring programs, PDMPs, to track prescribing patterns and identify potential misuse. DEA efforts focused on diversion and illicit trafficking. Major research initiatives like the NIH HEAL program, funding studies on pain mechanisms, non-addictive analgesics, and addiction treatment, and significant litigation against manufacturers and distributors seeking accountability and funding for prevention and treatment.
And the fentanyl crisis layered on top of this just made everything worse.
Dramatically worse. Starting around 2015, the nature of the crisis shifted significantly. Overdose deaths became increasingly driven by illicitly manufactured fentanyl and its analogs, often mixed into heroin supplies or pressed into counterfeit prescription pills, frequently without the user's knowledge. Its extreme potency means tiny errors in mixing can be instantly fatal. While supply reduction efforts continue, the long-term solution must focus on reducing demand. How do we reduce demand? It requires a comprehensive, sustained societal effort, widespread adoption and insurance coverage of multimodal non-opioid pain strategies, safe and supportive opioid tapering protocols for patients on chronic therapy, greatly expanded access to evidence-based treatment for OUD, including methadone, buprenorphine, and naltrexone, integrated with psychosocial support. Breaking down stigma is key here. Major investment in addiction medicine as a specialty, and the continued urgent search for novel, effective analgesics without abuse liability. That remains a critical scientific goal. This is truly where science, policy, clinical practice, and public health must all intersect.
It's been an incredibly deep journey today. We've gone from the opium poppy through the intricate molecular dance of receptors and signaling pathways, explored the profound effects throughout the body, the clinical uses, the dangers, the specific drugs, the reversal agents, and finally, the societal crisis. This deep dive, we hope, has armed you with that comprehensive, professional-level understanding of a topic that touches millions of lives.
It's a field defined by both immense progress and significant challenges. From isolating morphine to designing biased ligands, our understanding has grown exponentially, yet the complexities of pain and addiction remain formidable.
So as we wrap up, it leaves us with a really provocative thought, doesn't it? As we continue to push the boundaries of science, understanding pain pathways with ever-increasing precision, can we realistically create that perfect painkiller? One with profound relief, but without the devastating shadow of dependence, overdose, or debilitating side effects. And perhaps just as importantly, what responsibility do we all share, clinicians, researchers, patients, society, in shaping a future where pain is managed both effectively and compassionately, balancing relief with safety?
The quest continues. The science is exciting, offering genuine possibilities for safer, more targeted therapies. But it requires ongoing research, critical thinking, and a commitment to applying that knowledge wisely and ethically. The evolution of our understanding is constant, and the potential for future breakthroughs is very real.
Thank you so much for joining us on this deep dive. We encourage you to continue exploring these vital and complex topics.